not only welcome, but comfortable to be able to come forward and present when necessary. So studies have shown that Black women are twice as likelier to experience infertility than white women. And when Black people attain access to reproductive treatments, they experience lower success rates, lower live birth rates as well compared to white counterparts. So we're trying to break that mold. We're trying to have access more to people of color, as well as to be able to let people know to present much earlier than we typically do.
Absolutely.
So poor outcomes are disproportionately seen. As we mentioned before, we have lower implantation rates, lower clinical pregnancy rates, increased miscarriage rates. A lot of time we feel like we're the only one experiencing this. Many times if you go on websites, on fertility websites, you walk into a clinic, you see pictures or couples posted. It's usually Caucasian couples. So we feel like we don't belong in that space. And you tend to feel that when you experience infertility that you're probably the only one going through it because you don't see other people looking like you coming forward, which is great that we have more people very vocal about it, especially when we have public figures like former First Lady Michelle Obama. We have Gabrielle Union, Tamron Hall, and a lot of other celebrities coming forward and giving their story, that people would know that this is not uncommon. Miscarriages is something that does happen, or infertility as well. And it does happen in the Black community. We're not always super fertile as, it's usually appears. And hearing more voices of it make you understand that, you can present earlier, and this is something that you can feel comfortable coming forward, telling your physician, your PCP or your OBGYN about, to get worked up much sooner.
Mm-hmm. Now, Dr. Jackman, what do you think creates that stigma around the hesitancy of sharing, or maybe sometimes feeling like we're alone, where people don't share these commonalities or experiences amongst each other?
Oh, there are so many factors for this. A lot of it is kind of rooted also in the history of the country. Black women have historically been portrayed as super hyper fertile. A lot of times it's concentrated on, contraception, and we completely forget the other half of the conversation, which is conception. Okay, so it's good to know how to prevent a pregnancy when it's unwanted, but when to intervene and what next, we never really pick up that end of the conversation. We kind of leave it hanging halfway in the dust. So historically, we have been portrayed as super fertile, so it never really thought of that Black people could experience infertility. It seems like something we shouldn't be able to experience. And it's also taboo discussion in a lot of Black communities and culture. I'm from San Diego, and I can tell you that slowly it's evolving, but still very slowly. People still don't talk about infertility or the different conditions that they can have that can affect fertility. And religion has a big part to play in it as well. We are a very religious community. We tend to be a very religious community. A lot of Christians we tend to be a lot of Christians as well. And there is, in Christian faith, it's a thin line of, how far you can go. And a lot of people, when they think infertility, they automatically think IVF. Realistically, there are so many things that can be done before IVF. And in some cases, IVF is needed, but it's also important that people are educated to realize that even if you're not comfortable with one sort of management, that there is a gamut array of things that can be done. And IVF is not the only solution to infertility. There are other things that can be attempted if, one aspect is not comfortable for you as well. So those are a few of the reasons that I would say, and I can go more into it too later on in the presentation, but those are definitely a few of the reasons why a lot of people are hesitant.
Thank you for sharing that. I seen a really good question. I think a lot of people would love the answer to, but what age do you recommend testing for fertility?
So previously, it was like very experimental to say, whether or not you should assess fertility, because egg freezing and embryo freezing, those things weren't part of the norm. And because now it's introduced that you can socially do egg freezing and fertility preservation, I would say when it's a good time to do it, whenever you're comfortable in terms of like just getting a baseline. So I would say get a baseline, but definitely look in your 30s. I wouldn't go too far beyond knowing what a baseline is. And fertility assessments, entail a history, an ultrasound, some blood work, and we can give you a baseline. Now, nothing tells me the answer to the question whether or not someone can get pregnant, and that's very important to know. But just knowing how you may respond to treatment if needed, as well as different factors of your fertility is important, because it may help us guide you along the way as to when you should probably seek care, whether it's sooner or later. So these are a couple of things that I think that, can be looked into. And I definitely think mid-20s is a good time to just have a baseline, even if you're not considering at this point.
Wonderful. Thank you for sharing that. We'll go into the next slide. I'm going to have Dr. Wood speak on that next slide. And there's some really great questions in the chat that I'm also going to ask Dr. Wood for her thought process and opinion on as well.
Absolutely. What do you want me to absolutely, Dr. Jackman? Or I can as well. I'll start, and Dr. Jackman, please chime in with some of the medical aspects of this. And I can speak to this not only as a mental health provider, but also as a former patient myself who experienced infertility. And, so the different paths to parenthood is first, the trying through natural conception, which is an option for heterosexual couples, but, for same-sex couples, I think automatically they will have to begin to consider what are some of the other paths to parenthood if they are wanting to use genetic material outside of adoption. And then I think treatment options begin with things like, and as part of the assessment, right? So part of it is like exploring what are the aspects or the mechanisms to parenthood through natural conception that may or may not be working. So first is like, well, are you ovulating? If you are not ovulating, then we need to sort of induce ovulation and work increasing egg production, and then sort of working and building up that. And then next, moving up to intra-uterine insemination. Formerly, years and years ago, when I first started, it was called artificial insemination, but IUI, which, and if donor sperm is also needed, but that would be, we're still using, and I feel weird explaining this where Dr. Jackman is here.
Yeah, it's a
I can jump in.
So, Dr. Jackman, yes, please jump in.
So, yes, we do have many treatment options, and this is what I kind of alluded to. A lot of times people think of, infertility and they automatically think IVF, but there's different tiers and there are different levels, and it really depends on what you're presenting with, right? Which is why an assessment is very important when you're seeking, when you have experienced infertility. So ovulation induction, as Dr. Woods very nicely explained. So it's, if you're not ovulating, think medication that can help you ovulate. IUI, which is intra-uterine insemination, that's giving you a little extra boost. We're putting processed sperm directly inside the uterus. It gives the sperm like a much easier pathway to reach the tubes to fertilize the eggs. And we also monitor your ovulation in that sense as well. And then IVF is, usually, sort of the thing where if people have some hesitation, it's usually with that, with IVF. So there are other options. I need to take one quick minute to assess something. I'm sorry, I will be back in a minute. I do have to hold off. Okay.
Dr. Jackman is busy working.
Work doesn't stop. But Dr. Wood, I think a great question that you could answer, Dawn here. What is the best way or any tips on finding Black doctors near us? Do we just go on Google? Like, how do we maybe find a great provider and qualify them for our needs?
Yeah, no, that is a great question. And I think there's two parts to that, right? So one is actually like finding the actual like names and locations of doctors. And I think that Amanda Lynn uploaded a directory into the chat box. But I think the second part of that is also about comfort and being comfortable asking questions of your provider about things that matter to you, and sometimes that's what I do in my work with clients in anticipation of exploring these options. What is the information that you want to get? What's the kind of feel and vibe that you want to get from a provider. So it is one, I think the first step is, getting an actual like directory, which we have provided for you. And then I think it also is empowering ourselves with the kinds of questions and information that we want about insurance coverage and financial resources, their own successes, their philosophy about medical care and attention. Do they incorporate a holistic approach, if that's important to you? So I think that's, I think it's both of those are really important in identifying a provider for you.
Absolutely. Wonderful. All right. I think we can move on to the next slide here through the clinical components. All right. Dr. Wood, did you kind of just want to talk us through this one, just general?
Sure, absolutely. And I think that, what I can do is talk about some of these slides which relate to some of the reasons we see disparities and why we see African-American Black women maybe twice as likely to have infertility problems, but then also I think some of the resulting mental health stressors. So I'll kind of talk about both at the same time.
Absolutely. Absolutely.
Age is a related factor to fertility, and around age 35 is at the point where doctors typically consider fertility to decline, but it's not like a switch that just turns off. And again, as part of the assessment, those are things that are measured to give a sense of where you are. But what we do know about as women is that our eggs, we have all of our egg supply at birth. So as we age, we lose them. So we use them or lose them. And I think part of our goal today with this is to provide this kind of psychoeducation and information. And I think that's part of that. So realizing like, it's not just that there's a switch that turns off, but that as we do age, there's sort of an incremental loss to our not only egg quantity, but also possibly egg quality. And it's not only for those of us over age 35, but also for women under the age of 35. About 1 out of 10 experience premature low ovarian reserve. And I think there was a question before about the age at which to get sort of a fertility assessment, and my first thought was like do it now, in a sense, because I think we have that like age 35 or age 40 in our mind, which is part of why we maybe delay seeking treatment. But if there were things that we knew at 27 or 28, we would have been at least informed with information about ourselves, so that we could have made different kinds of decisions along the way.
Absolutely. I love that you touched on the fertility assessment, which we are going to talk about a little further, but I don't think a lot of people even realize or know that that's even available to them, right? So, right. I'm excited to even just talk about that a bit. So that's coming very soon. We can head to the next slide.
I was just saying that both is about quality and quantity, and that both does decline over time. But quality trumps quantity, and that is impacted by age. And it, may have different kind of outcomes and results for women. And I think especially for women of color that we have to be mindful of as we begin to age.
Wonderful. All right. Moving on to the
next. I see a question about advice on where to find African-American egg donors that aren't expensive. And I just want to acknowledge the question, because I don't know that I have a great answer for you right now, but I think that is another one of those areas that contribute to the disparities and access to care for Black women. Is the availability and accessibility for egg donors as well as sperm donors that are also Black.
Now, why do you think that is? Or just your opinion?
My opinion, I think the things we're talking about today, I think this very conversation, right? I think the lack of conversation and communication in our communities about the need for it. I think the lack of understanding that infertility does affect us to such extent that we would benefit from this, and that this is how we can sort of care for each other. So I think honestly, it's just information and lack of knowledge that is needed.
Yeah. I can definitely agree with that. I actually did an egg donation in my early 20s. I think I was 23 when I did it at the time. because I wanted to find a way to give back to other families that were wanting someone that looked like me. It was a very personal, deep choice, but I just didn't understand. Now, being an almost 33-year-old woman, I didn't understand at the time when I was 23 the decision I was making and the rarity of my choice and the rarity of the availability that people would have if they, wanted someone that also looked like myself with their family building process. So amazing. Dr. Jackman, welcome back.
I'm sorry, I do have a patient.
Hey, we know maybe it's important. Well, you're just in time. We're literally just starting the discussion about the fertility assessment. So with you being right there in the clinic, maybe you can elaborate on it more.
Yes, I actually want to go back the slide right before this. Yeah, so I just kind of like to elaborate this because I think it's like very important to know that as women we're born with, and it's probably was stated, so I'm sorry if this is a repeat. As women we're born with all the eggs we're ever going to have. And I like to think of the ovary as a big bank of eggs, and you get the full deposit at birth. From birth to death, you're just going to be making withdrawals every single month. So kind of think of it like that. So you just know that because you have your full inheritance at the beginning of life, that the number will always get less and less. So at birth, we estimate that it's about 1 to 2 million, and puberty, we're already down to about 300 to 400,000. By the age of 30, we're looking at roughly 180 to 200,000. As you can see, it's declining every single month. So kind of in conjunction, which we will mention on the other slide with the ultrasound, I like to think of your ultrasound as the ovary is making a withdrawal every month, and the ultrasound is what picks up that withdrawal. So you're able to see what's out of the ovary for that particular month on the ultrasound, and it's called the antral follicle count. This is part of your fertility assessment. Quantity is important, but obviously quality is also maybe even more important, because it's nice to get 100 roses, but if it's 100 dead roses, you probably will not want it, okay? So we need to have quality as a factor as well. So with quality, there is no ultrasound or blood test that can do quality. Quality is more as a product of age. And while both quantity and quality is a product of age, and quality is solely a product of age as far as we have for now. So less than 35, we expect about 70 to 80% of eggs to be still of good quality. This is provided you have no, chronic use, no severe medical conditions, accumulation therapy, then it will be directly related to age. So under 35, 70 to 80% should be good quality eggs. From 35 to 37, we're looking more like 40 to 60%. So still decent. 50% of your eggs are still really good. Then at the age of 40, this number drops 20 to 30%. And then over 44, we're looking at less than 1%. So as you can see, there's a gradual decline in quantity as well as quantity when it comes to increasing age. So I mentioned that the ultrasound looks at the withdrawal of follicles for that particular month. And when you do a withdrawal, what do you want to know from the bank? What's my balance, right? What do I have left? So that can be done by a blood test. It's called anti-Mullerian hormone, or AMH, and that looks at the ovarian reserve. Any number, we have a threshold cutoff 1 to 6, so number between that's considered normal. And this more tells us not what we're actively withdrawing this month, but basically what we have left. The number is not a direct representation. So if you have an AMH of 1 or 2, it doesn't mean you have 1 or 2 eggs. It's just to represent that you have, eggs left in the reserve. So those kind of things I like people to know early, that, both quantity and quality is impacted by age. And knowing this is very important because, as I said before, we're always talking about contraception. We need to also introduce the discussion on conception, getting pregnant. So we can go to the next slide, unless there's a question. I know Dr. Woods and Renee have been talking about this slide, and kind of linked to what I said before. You do the fertility consultation, we get the 101, we do the ultrasound, know how much you're withdrawing this month, we get the blood work, and know how much you left in the reserve. And with all this information, we can come up with a good plan for you. So what does it really mean to be infertile? So the definition of infertility is the inability to get pregnant or to stay pregnant of trying. And this definition is suitable for anybody under the age of 35. Once we're 35 and older, we like the threshold to be a little more stringent, and we say after 6 months. Doesn't mean that you have to really wait for that entire year or wait for 6 months. I would say you wait for what is comfortable to you before you present. But what the definition I would say is using 12 months and 6 months as a cutoff, not to go beyond that time frame. But definitely, if you're like very nervous and you want to get assessed earlier, we will not deny you to get assessed earlier. We just don't want you to wait like 2, 3, 4 years. And lots of times we have patients presenting after years of trying. And that's really where I think it's very important to know these cutoff thresholds. Just be mindful though that if you have like any conditions like endometriosis or anything affecting the reproductive system, that we would probably err on the side of the shorter time frame, even if you're younger, as opposed to within an entire year. And about 1/8 of couples experience infertility. A third of cases are male infertility. That being said, I would say about 50% of cases contain men, meaning a third is solely male factor, but then you do have double factor, meaning male and female infertility. So if we do combine male and female plus just male, it's about half the half male infertility. And I said this because a lot of times women are blamed as and women are the ones who seek follow up and feel guilty. And some societies, I can tell you, definitely in Caribbean culture, are men like macho. We don't need to get assessed. It's not us, it's you. And I want to know that the one men and men who are listening today, or in future as a superior, there is contribution. It takes two to tango, literally, in this sense. And we need people to know that it's not about a blame whose fault it is. It's a we problem, not a you problem. Even if it's one gender versus the other, it doesn't matter. It's us and it together. So, definitely coming to the appointments together and understanding the full gamut of infertility would be beneficial to the couple. Whether it's a heterosexual couple, whether it is a same-sex couple, really doesn't matter. It's a we problem, and we should come because we're trying to get pregnant, not just you.
Absolutely.
So there are biological factors for infertility that are prevalent in the Black community. And fibroids, I'm sure everyone listening here today must have heard of fibroids before, whether you have it, your relative or friend have it, or you just kind of heard the word buzzing around. A fibroid is a benign growth in the muscle of the uterus or the womb. It could occur on the surface, inside the muscle, or on the inside the cavity. And it's unclear why Black women have a predisposition for uterine fibroids, but we do. Maybe genetic, maybe hereditary, we do have a higher rate of uterine fibroids, and these can affect our fertility. It can cause miscarriages. It can cause preterm labor and delivery. So definitely knowing about fibroid, if it's a diagnosis, and if your fibroid is numerous or in a size or a position to contribute to infertility, is very important to know, as it disproportionately does affect the Black community. Another thing is, if you're going to treat fibroid, I always tell patients, you spend how many hours choosing a phone, how many weeks choosing a car, and how many months choosing a house. You want to put as much dedicated time between choosing a doctor and a provider, especially if you're going to have surgery. So take your time, know your surgeon. Make sure your surgeon is really good specifically for what you're going for. You'd have excellent surgeon. It just may not be the best surgeon for that procedure. And really take your time to make sure that you're choosing the best. Because once you do something, we can't reverse it. And a lot of times, if you some Black women present for fibroids, and the recommendation is that hysterectomy is the only option. And it's not really delved into the fact that, well, if you do hysterectomy, there's no way you can carry your own baby in the future. So it's going to render you infertile naturally. We can still get a way around it, by doing IVF and using a surrogate. But a lot of patients actually don't know sometimes that, the hysterectomy is going to mean you can't naturally conceive anymore. So really ensuring that your provider really gets you and understands you and is doing, best, not just for the situation at hand, but for your future reproductive goals is also important, especially when it comes to fibroids.
Now, for women dealing with fibroids, are there any specific questions they can ask a provider to kind of determine if this is the right provider for me or not? Any suggestions there? It sounds like it's pretty common to deal with fibroids.
It is very common. I would definitely want to know if my provider deals with a lot of patients with fibroids, the frequency, if they do a lot of surgery, if they do a lot of minimally invasive surgery. Now we're kind of getting in a way of doing anything open. So you want to make sure that your surgeon is like a good laparoscopic and or robotic surgeon, how comfortable they are with that. And then you just listen to their treatment plan. And if something doesn't sit well, getting a second opinion, never hesitate for it. It may cost you to, the visit, the consultation fee, but in the end, it will be for your benefit because it costs more than your health. So I always recommend getting a second opinion if you feel like you're not comfortable with the plan, especially if the plan may ultimately affect your fertility. So a hysterectomy, removing the uterus completely, is definitely going to have an impact. But even someone who's doing a myomectomy, understanding how many fibroids, how big they are, and how likely would that provider be able to approximate the uterus, because once you remove a fibroid, now we have to kind of build back your uterus. And you want to know how likely it is for that to happen. So these are some of the questions you should ask, especially when fibroids is a concern.
Someone did ask a question here too. Why are we predisposed to so many reproductive issues as Black women?
That is a great question that I do not have an answer for, but it is true. And I think that educating yourself and knowing that it's there and knowing how, like, when to take action is very important. I'm honestly not sure anyone has the answer to that question just yet, but, it's unfortunate, but a lot of research is done on men and not on women, so not for many reproductive things. And when it's done, the demographics is usually Caucasian. So it's very difficult to ascertain that answer at the time, but it would be very interesting to know why as well. I'm interested in that answer.
You and me both, absolutely.
So other risk factors is a condition called endometriosis. Now, endometriosis is a very common cause of pelvic pain, and it occurs in about 20 to 25% of women with infertility, which I can tell you, I did a fellowship on endometriosis, and I think this is a super underestimation because it's not really sought out for many times. And if we don't seek for it, we don't find it, right? So I think this is a very lower number, but even if we're going with 20 to 25%, that's a quarter of people with infertility present with endometriosis. The problem is it's commonly thought that Black women do not have endometriosis, which is also not true. It's thought to be a disease prevalent in Caucasian. So because we don't think it happens in the Black community, we don't look for it a lot in the Black community. So it's going to be missed a lot. So there aren't many studies about it either. So definitely factors like endometriosis, and I see someone mention adenomyosis, which is similar. So these conditions are when tissue that's very similar to the lining of the uterus is found elsewhere, whether it's found in the pelvis or found in the uterus. In the uterus is called adenomyosis, and being found anywhere else is just labeled endometriosis. And this can have a very inflammatory response, so it does affect fertility. The problem is that, we don't have much studies on it in Black women, and we don't tend to look for it. Another problem is that if we find any condition that may be more obvious, it usually gets the blame. And what I mean is fibroids. So you may have somebody presenting severe pain and bleeding, but they have one small fibroid, and you're like, it's the fibroid. The fibroid is probably 1 centimeter and it's not doing anything, but the point is you have something that's obvious that can be seen, and you ascribe blame to that. Anything else, whereas it may be a dual factor, or it may not be the fibroid at all. It may be endometriosis, so we don't tend to look for it, so one we will not find it.
Absolutely. Now, I see some talk in the chat about herbs and holistic care and health. I'm an advocate for. I've been a holistic health coach for a little over 4 years. So tell us your thoughts and opinions when it comes to endometriosis and fibroids and maybe just, holistic practices.
So it depends on what they are recommending. So if you're talking about things like acupuncture, mindfulness, yoga, meditation, I definitely think that these practices are great adjuncts and great, I don't like to say alternative, I like to say, complementary medicine. Complementary gives you the aspect that you can do this in addition to and not either or. So I think definitely doing some of these things in addition to seeking out medical care is definitely great to consider. Just bearing in mind that acupuncture, meditation, mindfulness might help you to cope with symptoms, particularly if it's pain. But it's not necessarily likely going to get rid of the endometriosis itself. So therefore, the factors may still be present. But I would never hesitate to tell patients can do this in addition to seeking care, especially fertility is the main problem that you're trying to seek. Are you guys hearing me clearly? I'm seeing pop-ups about the audio.
You're a bit choppy. I think it's your connection or maybe your location in the clinic. I don't know if you can pivot by chance, but you are coming in and out.
Okay, let's see. Okay.
All right. Well, this actually leads us into the next slide, I believe, which is a bit about diet and lifestyle. If you want to elaborate on that there for us.
This next slide is on PCOS. I'll just do this one first before diet. So polycystic ovarian syndrome is also another factor that is prevalent in the Black community. It's basically a misnomer. I don't like all the name because it's not really cyst. So as I spoke about follicles before, follicles are like your egg houses. Polycystic ovarian syndrome is just multiple follicles on the ovary. And the main factor of this disease is that you tend not to ovulate. You're not ovulating. Because you're not ovulating, you are just having all these follicles that are not getting mature. You're not releasing that egg in them. So it's really characterized by having irregular periods. The irregular periods is as a result of not ovulating. You may have increased male hormones, and then you have the polycystic appearing ovaries, which I prefer to call the multiple follicular appearing ovaries because they're not cysts. Cysts do not have eggs in them, and you definitely have eggs. So staying active, maintaining a well-balanced diet is recommended. Definitely is the first line treatment for polycystic ovarian syndrome. But it is indeed a very common endocrine condition, the most common endocrine condition in women of reproductive age. So this is also something that we need to assess. And there's a big misconception that someone with PCOS have to be like obese, they're bigger in size, and that's not true. I have PCOS, and a lot of people may not fall into that stereotypical mindset, have PCOS. So just knowing that these characteristics that sometimes we ascribe to PCOS is not always true. So you need to broaden and know that if you're having irregular periods, that it's good to get worked up to find why PCOS may be a factor, regardless of your size.
Now, I have PCOS as well, and I wasn't actually diagnosed until about 6 months ago when I did a fertility assessment at our clinic here in Atlanta. And I was so surprised because I started to learn that a lot of women with PCOS either go misdiagnosed or undiagnosed for extensive periods of time. Why do you think that is?
Well, one major reason is that a lot of women are placed on birth control pills very early on. And with the birth control pills, you're going to be regular. It is a treatment. So you're going to be regularly ovulating, regular periods with birth control pills. So easy to miss someone who may otherwise have an irregular period if you place on birth control pills very early on. So that's one reason why it tends to be missed, because you're on birth control all your life. So as far as you know, well, my periods are regular because I, stop taking the pill one day and it goes away. So that's fine, right? So that's one of the reasons I believe that, PCOS can be missed. Another reason is the fact that it's very easy to miss something if we're not looking for it. If we don't take the diagnosis, so you go to a provider and you tell them I have irregular periods, but to you it's like meh, because maybe you don't really mind not getting a period every month. So some patients don't necessarily focus on the symptom, or some providers don't focus on the symptoms when it's presented by a patient, because it's not really affecting you as far as you can see. Instead of trying to get pregnant, so I'm like, I really don't get it. I don't get a period every month because I'm not trying to get pregnant right now. So you never really look into it until, much later, and then you find it.
That's true. Very true.
So now we come into like lifestyle factors that can influence your fertility. So it plays a very important role in our ability to conceive and stay pregnant. Definitely you want to stay active and maintain a well-balanced diet that is recommended. It is also one of the first steps in treating PCOS, as I mentioned before, but in overall, having overall health is important, not just for PCOS, but also just for infertility in general. So it's one of the first steps that we can take. If you smoke, drink alcohol excessively, these are all things, or use any illicit drugs, these are all things that we can all modify to help the initial aspects of improving our infertility. Doesn't mean that automatically if we diet, exercise, stop smoking, we're gonna just go from not getting pregnant to instantly pregnant. Probably not, but these are definitely the first few steps that we can take for ourselves to help in that regard. Yes, so we can move on to, we have it. So other behavioral risk factors, so mental health and stress, and I know we're going to delve more into mental health with Dr. Woods, but mental health and stress can also affect fertility. It's not a direct one-to-one relationship, but definitely severe stress. If you're very stressed out, then your body's has a lot of hormones, a lot of cortisol. You're not in the frame of the body is not in the frame of let's try to get pregnant, right? So infertility in itself may cause a person to feel stigmatized, therefore also contributing to anxiety, depression, and stress, further impacting infertility. So it can be like a little rough cycle. So a lot of times in the Black community, and Dr. Wood will speak way more about this than I would, it's very stigmatized and taboo to talk about mental health and to seek care for any conditions we may have. Your parents always have these cures, either whether it's just you need to go to church more, you have to pray more. There are always these little quick cures that we think we can do for this, and definitely be more comfortable to seek mental health as well. As I think this is something that you just automatically be in. You see your PC, you see your GYN, you see your therapist or your mental health provider. It should be standard and part of routine baseline care. It's not as yet, but definitely working to try and have that as part of a normal everyday occurrence would be a much better way. So you don't have to feel like I have to go to seek mental health care. It'll just be part of your routine, month, every 2 months. I don't know what the time frame should be, but definitely it should be regularly scheduled, not something if you stigmatizing, you have to whisper about it. I have to go see somebody. It's something you should feel comfortable doing.
Mm-hmm. Now you're still getting a little choppy, so I don't know if the movement really helped much, but there is a really great question that I wanted to ask you. Someone said they had a doctor tell them that their plant-based diet is not helpful to their fertility and they should be on keto or low carb. What are your thoughts on individuals who eat a plant-based diet for fertility?
I definitely don't subscribe to the fact that patients should definitely be keto or one particular diet or the next. Definitely there are a lot of vegans out there getting pregnant. So I don't subscribe to that as well. I think when it comes to diet, ensuring that you have a well-balanced diet, making sure that you get certain percentages of each food group. And we know that even though meat contributes to a lot of protein, there are a lot of plant-based proteins as well. So I don't subscribe to that personally. And I don't think that's true. I just think having a balanced diet, you having a lot of fresh fruits and vegetables is very important. Making sure that you encompass proteins, whether it's plant-based or animal-based. Protein, I think, is important. So I'm not too sure if there was more to that conversation that we're missing, but just as it was phrased, I don't agree with that.
Thank you for your opinion there. Thank you.
So socioeconomic disparities in fertility do occur. Health disparities in minority populations are not new, but more awareness of this is being continued to be brought to our attention. So basically taking steps to try and diminish this as much as possible, being able to highlight not just that it's happening, but also to have a corrective measure, which is, having more forums, educating the public more often, ensuring that we have more programs to get more assessed is all very important. And this is where Kindbody is taking that initial step in education. Because nobody's really free until everybody's free. And I think that's very important to hone in on.
I agree with you. Dr. Woods, I would love for you to take over the next slide and start elaborating a little bit more with the socioeconomic factors for sure.
Yes, absolutely. I think part of why, again, this is such an important conversation is to improve our health literacy and get more information and understanding about how to take care of ourselves and what we can use to sort of the tools we need and the information. Because without that, I think it leads to a delay in family building, and speaking even from my own personal experience, I too sort of, bought into the stereotypes about Black women not having any trouble getting pregnant. I have 3 older sisters who did not have trouble getting pregnant and, thought it was okay to wait until after I got my degree and after I got married, and wasn't until I was in my mid-30s that even started asking some of these questions that we're learning about today. And so I think there's a delay in family building, and or just for personal preference. So there's a delay. And then once, maybe we do encounter some difficulties, I think, particularly in the Black community, like I said earlier, even though we may be twice as likely to have difficulties conceiving, we're half as likely to go seek services, and we wait to go seek services. And I think that's informed by many different things, representation, as Dr. Jackman mentioned before, as well as cultural barriers and the stigma attached to it, as well as religious beliefs. And I want to be clear as I say this, that these are not, I'm not talking about these as though they are weaknesses or deficits or criticisms, because my faith was the thing that also got me through my fertility journey, right? And holding on to that. But I think there also was a part of it that was, as Dr. Jackman alluded to before, that was like, pray more, go to church more, wait on God. And at some point I was like, wait, I think God has provided all of the tools I need, but I haven't accessed myself to those tools. So, so I got to do a little bit more work. So that it's not a criticism, but I think we have to be mindful of those things that may be delaying us reaching out for help and talking with each other, and our systems are not set up to take care of us. That question before about why are Black women, so there's so many disparities and reproductive health with Black women. And it's not just reproductive health. I mean, we are at greater risk for heart disease. And I think it's just very complex. And we can think of all the racial and systemic and economic factors that play into that. And that is true in infertility as well. Our government services and insurance coverage is just not designed to work with us. And, I won't go into my conspiracy theories about why, but, there are many, many reasons. So there's misperceptions, misinformation, and just getting information like this is just so important to at least reduce the impact of some of these on our reproductive health.
Yeah, I agree with you. And I kind of come from a little bit of a different angle with agreeance because I'm a baby loss mom, but I lost my son 36 weeks in my pregnancy. And in looking back, that's what allowed me to learn how to kind of better advocate, better ask these questions that you elaborated on, better seek understanding and seek knowledge and seek knowing, just to be able to understand like the process and the outcome and things like that. So as people navigate these fertility journeys, going through either infertility or getting to a point where they conceived or maybe they miscarried or, getting to the stillbirth process, it's all just very hard to deal with. But these disparities can also contribute in different ways too, for sure.
Mm-hmm. Yeah, absolutely. Absolutely.
Someone asked a good question that I would love your thoughts on. They said, I'm a non-traditional pre-med student and would be curious to know if some of these biases Black women are facing in the medical community are being addressed in med school curriculum.
That is an excellent and fabulous question. I'll give my thoughts, and Dr. Jackman, I would love to hear your thoughts as well. I'm hopeful, but not to the extent that I think it's making any sort of immediate impact. I think bias is exactly the key word in the question, and the acknowledgement of differences in our body's reactions to chemicals and the things that we are exposed to. And I think earlier in the chat, there was something about response to someone when they were knowing that they're having hormonal changes and noticing differences in their hair, and the doctor saying, go see a dermatologist, and I am hopeful because we're starting to have these kinds of conversations and there's much more attention to the disparities, but change can also be slow. Dr. Jackman?
I honestly think it may be, well, I mean, I'm far along out of med school, so to talk about updated curriculum, I can't really say. But I do believe that it would probably be integrated in the curriculum. I just don't know if it's a serious integration or if it's a check the box sort of integration. And based on a lot of companies, the way that they address health, not health disparities, but disparities in the workplace, it's just usually like a course that you have to take that I can tell you people usually just kind of click through the course to have it ticked off that they've done it. But it takes a lot more, unfortunately, than just doing a course every couple of months to really change mindsets. So it is a start, a very slow start, but much more would be needed to be done to change your mindset, right? And there are a lot of biases that people have that they don't even realize they have, which is problematic in the first place because you don't even realize that you have it. But just simple things, which is not necessarily directly related to fertility, but the fact that, they thought that Black women don't experience as much as pain. And there was actually a study very recently done amongst medical professionals, ranging from medical students to all the way to like attending doctors, and you would be surprised at the high levels of people who actually thought this to be true in the medical field. So simple biases like that just are pervasive and percolate, are difficult to be corrected with just a simple course introduced in the medical school curriculum. It really comes down to getting it over and over done that everyone should have the same access. Everyone should be treated equally. Everyone should feel comfortable to seek it, and then ensuring access to care. What are our insurance plans looking like in cases with lower socioeconomic communities? IVF is not even remotely in demand, and it's not being discussed. And I understand that people of lower socioeconomic, IVF is still very expensive, but it shouldn't be the fact that you need to consider completely perception of whether a person should be afforded or not. So there's a lot more that should be done, and slowly like this will help, but there's a lot more way to go.
Absolutely. Thank you.
And I think this gets to the conversation about advocacy. And I think we have, I'm not sure, I think the next couple of slides began to sort of touch on that and what we can do to improve some of these gaps. So if we can advance, I'll go ahead and sort of lead into that, but we can advance to the next couple of slides. Because as I think this is what we were just discussing about, that access to care is not always convenient or affordable. And there then also may be the sort of emphasis on privacy and stigma within our community, so that further inhibits us from proactively seeking services. And I think some of the strategies to try to improve this is the things like we're doing today to address the education gap and just providing information and resources to ourselves and within our community, thinking about the makeup. Oh, I'm sorry, I think I'm already on the next slide. Thinking about some of the things that have been raised, especially in the chat box, about representation and who is available to provide care, and the makeup of office staff and clinics, and just really sort of normalizing this conversation and our experiences. I've been following along in the chat. It's been so active. It's been hard for me to keep up, but there's so many shared experiences that everyone has had, and from all over the world, and probably in our local communities, feeling very isolated and alone in the things that we're dealing with. But we get on this, this platform here, and we see how similar we are and how many of us have gone through this. And I do think sort of empowering and enabling ourselves with information is a key to that. And so kind of back to that conversation about, the bias that we see. One of my own sort of stories about this and how information can be powerful. I'm a psychologist and a scientist. And so I, look to the research, and when I ended up in this field as a patient, I started doing my own research. And it was interesting because I was working with a physician and loved the physician. And he and I were having a debate about whether to use a frozen embryo or fresh embryo. And the information is not consistent on this, but I came across an article that showed that for African-American women, frozen embryos had higher birth rates. So I just printed out that article and I brought it to him. I said, I know what you're thinking, but this is what I'm reading. And I just want you to see this article right here. And we did a frozen cycle that resulted in a live birth. I don't know that was it. It probably were many other things, but it was very important for me to arm myself with information and have a voice in what was going on. So I think all of this is really important in that. And because you will encounter, I think, whether it's stereotypes or bias or just sort of like, well, what the global research is saying, and sometimes that might not attend to the local knowledge that we have about our bodies, ourselves, and our experiences. So, are there other questions? I think we could, I think, I'm not sure if yeah, thank you. I was like, we can advance. So these are some of the things that I was just speaking about. And Renee, you have done such a fabulous job, and you've made reference just a bit ago about your own experience, but I want to hear a little bit more, if you don't mind. I want to invite you to share a little bit more about your own experience.
Yeah. Yes, absolutely. So I'm on this pretty HD camera, which may change soon because it's dying. But nonetheless, I've had a pretty interesting journey. And I think I resonate with so many individuals on different spectrums. In my early 20s, I did an egg donation. When I was 26, 27, I got pregnant with my son, who ended up in a stillbirth, 36 weeks in my pregnancy. I am currently now, my birthday's in a few days, but I am 32 now, navigating breast cancer stage 2. And I've done 2 egg freezing cycles with Kindbody, which I am just like, would have never expected or thought that I would have been at this point in life to do this again. But I'm so grateful for the knowledge and the opportunity. I'm grateful that I had made the decision to do a fertility assessment with actually one of our providers locally in Atlanta, Dr. Garvin. I did my fertility assessment with her, and who knew? I learned so much about my body, my follicle counts, like just so much. And that was just on a whim. And here we are a couple months later, I ended up with this diagnosis, but being able to be amongst a team of experts to navigate this journey and this process for me has been like super profound. So I am scheduled for a double mastectomy in a month from now. So this is where we are, but I'm grateful that I have my eggs frozen. I'm just grateful for chances and opportunity and education and knowledge. And that's what pushed me into the holistic health practices and even practices I'm utilizing to navigate breast cancer right now too. So I advocate for people, everybody, especially for minorities in this space, be a voice and advocate for yourself. I will say that 100 times over, and I cannot say that enough. Advocate for yourself, take the time, get educated. Don't let the doctor leave the room if you don't know what's going on. Like, just ask all the questions. And that has been my biggest, probably my biggest touch point in my healing journey thus far. So I'm 5 years out from these situations, but the breast cancer is new. And I just encourage you all to just do the same thing as you are navigating this journey of infertility, or, learning more about your body, dealing with different hormonal imbalances and things like that. So I'm here to encourage, and I'm here to soak it all in. And it's God's grace that I can do all this with this demeanor. So I just want to be that light in that energy for other people too. So thank you for asking.
Absolutely. Absolutely. You're a light to us for sure. So thank you.
Thank you. And we appreciate you all for what you do, because your work is so big and it's so important, and it contributes to just the mental health and challenges that people can have, but you're also a resource and you're serving. So you and Dr. Jackman, we appreciate both of you. Hey. Okay, well, I think we touched on this side pretty deeply. So I guess we can move on to the next slide.
Yeah, and I think there have been a lot of questions about insurance. I can see the slide sort of making its slow reveal to us. And I think that definitely is one of the key aspects about access to fertility. And I think we've talked about advocacy and speaking up for yourself at the doctor's office. But I think also we have to become a force and a voice with our representatives and our legislators to really encourage legislation to get mandated insurance coverage across the country. Some states are beginning to implement mandated coverage, and we're seeing that does create some dents in reducing disparity, but there's so much more work that can be done. So really, I think a lot of sort of, again, collective voices around advocating for, fighting for, supporting, insurance mandates that will cover this for everyone.
Mm-hmm. Absolutely.
Yes. And I think, if your employer is not providing insurance coverage and thinking about different benefit plans that will work for you, I think there are other ways too to think about advocating for yourself in terms of what you will need. And this, again, I don't want to say this without acknowledging the difficulty of this too, right? But it is, I love the way Dr. Jackman said it, something earlier about like taking care of ourselves and investing in ourselves. And if there's a need for reduced workload, reduced schedule, altered schedule, letting physicians know that there are some healthcare procedures that you will be needing, and that you will be using time for yourself to take care of that. Giving yourself space for that. We are historically and traditionally hardworking women who take on the burdens of everybody. We're not just, employees, we're mothers and daughters and sisters and friends and aunties and cousins, and taking care of a lot of people. So I think just taking care of ourselves and advocating for ourselves in the workplace and within our families. And sometimes I think that means setting limits with our families too. And saying, I know I've been here for you to do this, A, B, and C, but it is now time for me to rest. It is time for me to focus on this. And I think those are other ways that we can really advocate for ourselves in this process, to help get our needs met. We're not used to asking for help. And that is, I think, a huge part of this, is getting comfortable with that.
I absolutely agree. We are not used to asking for help, and we got to get comfortable with that. That is a tweet.
That is a tweet.
That is a tweet. Oh,
Yes, yes.
that's so good. All right, you can go on to the next. Okay, so I'm going to touch on access to care. I see some of your questions in the chat, so we'll definitely address some of those in a moment. But how are we working to improve access to care? We are working to improve that specifically by employer-sponsored programming that we're initiating, putting clinics in places that are accessible. So you all may start to see more Kind Bodies pop up where you are located. Of course, you can go on our website. I believe some of the team dropped the locations in the chat, but you'll start to see more locations as the months go by this year and upcoming. Diverse staff at all levels, diversification, we talked about that. That's extremely important because you want to feel like you walk into a clinic and care and you either see someone that looks like you can relate to someone that looks like you, and you just feel like you're getting the overall support on all levels. And making patients feel seen, welcomed, and included. That's something that we strive for. You'll notice that, representing itself in the services that we offer. And of course, like the experiences that we give to, we align that across all locations to ensure that you just feel like the priority that you are when you come in through the door. So that's part one. We'll get to the next. And insurance. I did see some insurance questions in the chat. I can definitely talk about this quite thoroughly, but we do accept insurance. Specifically, we accept Aetna, Anthem, Blue Cross, Blue Shield, Cigna, Empire, MultiPlan, Oxford, United Healthcare, as well as FSA and HSAs. The only thing I would throw out there is just double checking, once you do make an appointment at your location, just confirm. Sometimes newer clinics haven't been fully established with the contracting yet. So just confirm that your insurance is available. It never hurts to just clarify that question and just understand your summary of benefits as well. But we are in network with these insurance carriers. So it makes that process that much more accessible and affordable for you all when you're getting service with us. And of course, if you have any information, there's the website kindbody.com/insurance financing, where you can get more details from there too. So okay, and then Kind Body treatment costs. We have a special promotion code for you lovely individuals that are on this call this evening. You can utilize the code BLACKEXP22 when you go online to maybe book your fertility assessment, which I encourage everyone. This is 2022. Do not go another year or another month without checking on your body. So book your fertility assessment. Just at least get a good understanding of where you're at with that baseline health, and maybe decide, maybe you've been thinking about IVF this year or thinking about IUI, and, family building is on your vision board this year, whatever it may be. Definitely start with that step in that process to get in and meet with one of our providers. On the website, you'll be able to go and see if there's a Kind Body located near you. Of course, if you're by Georgia, you can come visit me. But nonetheless, we would love to have you regardless. So you're able to utilize that code when you go online and book for your services. And then that code is applicable to the assessments, is applicable to the egg freezing cycle, IVF cycle, and IUI cycle. So that's how much you're able to get off on each cycle, get off on that initial cycle, the discount code in that corner. So awesome. Go on to the next. All right. So Q&A, panel discussion. I know some of you have implemented questions in the chats that I've been trying to skim through and ask a few of them. I know a lot of them we weren't able to fully or thoroughly answer. Some of the team has been in the chat answering those questions too. And of course, a lot of those questions are going to be great for your providers when you do book your assessments and you're able to go in and connect and meet with the providers and bring your list of questions. Ask whatever you have to ask so you can get some clarity on your process. I do have a few questions here, and I'm going to try to scroll through the chat to touch on some more questions too, but a few questions. My first one is actually going to be for Dr. Oh, wait, no, this is an audience question. So from your perspective, what can we do to improve access and care? What's missing and what can we do better? So either Dr. Jackman or Dr. Wood, either of you want to touch on that? I think that's a good general question.
I can start, and Dr. Jackman, please chime in. I mean, I think that the nature of the questions we have actually sort of illustrate that. I do think increasing the number of providers is part of that. And I think in different geographic locations, right? And we've even, I think in the chat, I've seen some major cities that are maybe lacking in Black physicians and doctors, but I think also increasing not just the number of providers, but we've talked about also kind of coverage and reducing costs and identifying ways to get mandated coverage through insurance would be part of that. I think those are some of the systemic barriers, but I think also within our community, talking about it and reducing the stigma, like I said, just normalizing the conversation, talking about health broadly. I mean, I think in general, we could talk more with each other about our health and health related factors and mental health as well. So I think those are the things that come to my mind initially. Dr. Jackman, would there be others that you would offer?
I definitely agree with Dr. Woods. Definitely educating the general public, especially ensuring that you're able to reach minority and people of color to ensure that they get great education on their fertility and what it entails, and also great family planning introduction. So a lot of times our GYN are not, and I will include myself because I'm a GYN, we're not really catching people in general public because we're so focused on, the patient mostly is always focused on contraception, which is great, but also introducing the conversation, even if it's not brought up by the patient, introducing the conversation and being like, have you ever thought about family planning? At what age do you think you want to have kids? If you do decide you want to have kids, how many kids you want to have? And this is something I go through with my patients. And sometimes I not sometimes, I always draw a timeline when they give me like their recommended age that they want to have children and how many kids. And I do a timeline giving best case scenarios. And my best case scenario is that as soon as you try, you're going to get pregnant. And then I give you like 1 year for that child and then the second pregnancy. And that's the best case scenario. When you draw that out on the best case scenario, people really kind of put into perspective that, oh, wow, waiting till this age really is maybe late for fertility. So introducing the conversation much earlier on. And then, as Dr. Woods mentioned, increasing the number of people of color who are healthcare providers, because there are certain things culture-wise, community-wise, and just in general that we would hope that everyone will be able to empathize with everybody, but the reality and the statistics show currently that having a provider of color does improve your outcome. So we're only 2% right now, and we're not 2% of the population. So increasing Black healthcare providers in general would definitely increase better outcomes for patients of color. So definitely those things are some of the things. And also introducing, as I said, not just as a superficial conversation to get ticked off the list, but definitely having in-depth conversation about health disparities and coming up with real ways to address this in a meaningful manner is something that all institutions, not just med schools, not just hospitals, but all institutions should be thinking of disparities in healthcare, but also in other places, because the way your work life or your school life or different aspects of your life affects everything about you, right? I always tell my patients, they're not just a fertility patient or GYN patient, they're a whole person. So a lot of, like, when I screen for things and they're like, is this really a GYN thing? No, but you're not a GYN patient. I guess I'll start telling you, I'm sending you for colonoscopy. That's not my field, maybe, but realistically, are you seeing any other doctors this year for your screening? Most times patients just present to the GYN. So making sure we're kind of all encompassing and realizing that people are a whole and not just, that GYN patient or that pap smear patient. They're a whole individual, from head to toe. And that's how I like to address everything from head to toe. So ensuring that disparities are dealt with not just in health, but every aspect of life will also make a person comfortable in day-to-day living as well. So that's my thoughts.
Thank you for that. I want to kind of bounce off of that. What would you say Kindbody is doing to prioritize the care of Black women, make fertility options more accessible and welcoming, in your opinion?
Well, one, having seminars like this, making sure that we're educating and making sure that we're targeting people of color to ensure that the education is not just there in a bubble, but therefore that we have a target group is one thing. But also I think Kindbody is also diversified in our physicians, not just physicians, in our clinics. So our healthcare are very diversified. You will find, like rainbow of people from not just different races, but different cultural backgrounds, come from different parts of the world. So we're very diverse as a clinic on a whole, regardless if you go to New York, San Francisco, Los Altos, very diverse. And also ensuring that, we make access to care very accessible to patients in general. So not just through working through insurance, which we do, but also we have different third parties that we work with to try and help patients who may not be able to as easily afford, so like Future Family. We have a third party that we use, Future Family, ensuring that, we give patients multiple options to be able to access care, especially when it's related to fertility, when it can be really expensive. And then we're also trying to reach more companies to see if we can do partnerships, because if we're able to get more companies, including reproductive health within their insurance plan, that automatically means that more people can access it. So this is also a very important aspect that people don't necessarily think of, but insurance is a major gatekeeper, because if you think of it, a lot of decisions in healthcare, I might be, as a doctor, saying a patient needs X, Y, and Z, but then it's denied and insurance says no, and now I have to do a peer-to-peer and prove why medically it's needed. And insurance, a lot of the times, it's being denied because of a protocol written in a book. It's not like a doctor's reading all these things and saying no. So I'm just talking basically like it's being denied because of some protocol put together that's not all comprehensive. So definitely these are some of the things I think Kindbody is taking initiative of to try and address this as an issue. And I'm sure that there are other things that we have in plan as well that we will reveal. Then we have also this code. So if you take us up on that as well, it's also making the access a little easier to here. Definitely, please don't hesitate to use the discount code if you are interested in fertility.
Mm-hmm. Oh, absolutely. Why would you say it's important for patients to advocate for themselves? And why is it important for doctors to be transparent with the patients before they embark on their fertility journey?
Well, it's very important to advocate for yourself because no one knows you better than you. You've been with yourself for as long as you've been alive, and no one will know that any better. So sometimes, a provider might be able to give you a general overview of something, and you providing specifics to yourself would definitely change the conversation. Also, at the end of the day, we're all human. We're not perfect. So sometimes the first thing that might be, what we think of, you may read something else, or you may have more information to provide about yourself. And you're like, I know you said that, A is the route we should go to, but I read about B, C, and D, and I want to know why B, C, and D is not a route I can take. And sometimes that gets your provider thinking twice. Really, why didn't I recommend B and C? I can tell you why not D, but maybe I haven't really thought about B and C, or maybe I'm not well versed on B and C. As I said, we don't know everything. So sometimes patients do come to me with something new or something they read, and I tell them, sure, send me an article about it. Let me read more about it. I'll get back to you and give you my opinion on this, right? And I'm looking at who wrote it, if it's if it's a publication in a reputable journal, if it's peer reviewed, what was the number of people, whatever mechanism was tested on. So I'm analyzing this detail to know if this is something valid that we can consider, or if this is just, a thought or opinion. And then I will review it with the patient as well. So definitely advocating is great because we don't know everything as well, and sometimes, you know, it gets us thinking twice about something that we may have told you before. It's like, okay, maybe we can consider it this way. There's no reason not to. There was a second question that I kind of went off and I forgot the second part of the question, but that's the importance of advocating for yourself.
Thank you. There's a question in here that I actually thought was good. Kelly asked, does Kindbody offer education of any fertility awareness-based methods for tracking ovulation and health? Oh, I think you're muted.
That mute went fast. Yeah. So when you do a fertility assessment with Kindbody, we actually go through your history in depth. We do the initial ultrasound and examination, and we're able to give you tips on ovulation, like using ovulation prediction kit, and we will calculate how to use the ovulation prediction kit based on your cycle and like what you told us about your menstrual cycle. We also do fertility 101s at Kindbody, which will give you like a general overall, something like this, a general overall education on infertility and fertility. It goes a little more depth into it, obviously. So we do have education on fertility awareness, ovulation prediction kits, and different ways to do it, and definitely be good in specific things to you if you come in for a fertility assessment. And that's because obviously as a patient we kind of more in depth and we actually know your particular history. In forums like this, it's much harder obviously to individualize anything with, you know, over 100 people here, but definitely on the ones we're able to share specific information and tell you how to do it very specific.
Absolutely. Dr. Wood, I have a question for you. Just talking about mental health here, we know it can take a huge toll on us individually, but for couples specifically, mentally and emotionally, what do you suggest for patients and couples who aren't successful? What resources are available to them who have reached that point in their journey?
I'm going to start with the resources first. I think, you know, some of the things that we already talked about, like other mental health providers, family, clergy, and I really like being a part of the Kindbody team, because I think that building up the holistic health is a part of that. So there are resources in terms of connections, community, social supports. But I think my recommendation, and it may sound a little counterintuitive, because the question was how to help a couple that's not successful. But I believe it's important to recognize like different steps along the way and celebrating the different steps along the way, right? Because I think at every point in turn, we learn something about ourselves, whether it's something about our body or something about our relationship. And so I think, especially as a couple, I think it is really important to acknowledge the steps along the way. And I say this with couples that I work with, that, you know, you did an IUI today. We don't know the outcome of that. But last month, it was hard even to take your Clomid as prescribed. So this time you took the medication, you actually made it to the doctor's office and you got through the procedure. Let's just celebrate that today. So I think celebrating and recognizing that you are doing your best and you're doing all that you can, and acknowledging that. And then the other part of it is, I think, acknowledging the grief and loss that comes along with it too. That there is a grief and loss to the idea of how we were going to build our family, to what this was going to look like in the outcome. So celebrate all the steps along the way, but also I think give yourself time and space to grieve, and don't do it alone. Reach out to someone.
I love that you mentioned that, because unfortunately there are times where patients come in and maybe they didn't get the results they wanted going through the cycle the first time. How can we also care for our bodies and our minds as we're, you know, maybe not getting the results that we thought we would get, but we still have this vision and we still want to try again, and we're going to try again. But is there anything in the interim of those phases that we can do for ourselves to kind of care for ourselves, or seek out any tools from the toolbox, I guess?
I know, right? Yes. You know, Self-compassion, I say self-compassion is key, and it's like that one question of what would you say to a friend going through this, right? What would you tell a friend or girlfriend or partner going through this? So some self-compassion, some patience with ourselves. We get most frustrated with ourselves. Our body has betrayed us, has let us down. We don't know what's going on. So I think patience with ourselves, self-compassion. And also I think, remembering why this is important to you. In my clinical practice, I do a lot of what we call values-based work, and holding on to like, what are those core central sort of the purpose and meaning of life for you in this? And, nurturing another being, creating life, all those things that are at the core of some of this, and that we're still doing that. We are still parenting others in our lives. We are still nurturing. And I think that's what we can do to our body as well. We are creating the space for the things that we are working towards. And I think that is mentally how I talk about it, so that then we can engage in the behaviors that are consistent with our values on that.
I love that. We're creating the space that we're working towards. That's a really good point. This conversation has been extremely dynamic. It has been shedding light on so many new things, but also just giving us supportive ways that we can navigate our care, our bodies, conception, and anything along those lines. And I know so many people asked so many amazing questions, and we were not able to get to all of them. However, we do encourage you all to go ahead and take that next step, love on yourself this year, book your fertility assessment, connect with one of these two amazing providers with the company. There's just so many great things that can come about you taking that next step to, whatever it is that's in alignment with your vision, your desires in terms of conception and just overall wellness and well-being. Now, Dr. Jackman, can you tell us, where can people find you? Are you online? Where are you located again within the company so they can book a session with you both?
Yes, I actually don't know how people book with me. I just get my appointment scheduled. But I am on Instagram and
yeah. What's your Instagram if people are able to keep up with you? I think I see it listed.
Yes, thank you. Yes, so thank you. So I'm Dr. Wood. It's very easy at L Wood PhD. You can find me on Instagram and Twitter as well.
So I'm in the Silicon Valley region in California. So we have a clinic in Los Altos. So that's where I'm working. I'm also on Instagram. It's just my name, Janelle M. Jackman, MD. And that's the same thing for my YouTube handle. I probably will get into Twitter and all these other things soon, but those are the things I'm currently on. And I'm most actively more on Instagram. I haven't posted on YouTube for a while, but I intend to make that up soon.
Wonderful. Thank you for sharing. And if you want to connect with me, I cannot medically diagnose you, but I can give you encouragement and consistently share my journey with you. I am Hey Renee Ashley on Instagram, and I would love to. A lot of the questions that were asked are truly going to be great for you to connect with a provider in regards to your personalized healthcare and healthcare. Go ahead, go to .com, book all your appointments, and we hope to see you all very soon. So I hope you took something away from this call. Love on yourself the rest of this evening. Everyone has been amazing, and thank you so much for bearing with us, sharing your suggestions, encouraging each other in the chat. Y'all were fantastic. Everybody gets 5 gold stars. Thank y'all so much. I hope you all have a great night.
Bye-bye.
Bye.